We do. We have an iStat. There's 25 cartridges. I am told. I am told. Okay, so this is something that's a little bit more rare, but again, when it comes to the Ironmans, when it comes to long races, ultra distance stuff, this is something that you will potentially see. I don't have any disclosures. Okay, so this is low sodium that occurs in patients who are engaged in prolonged physical activity. Okay, I'm not a nephrologist. I'm not good at kidneys. That's just not my area. So this is going to be somewhat simplified in terms of pathophysiology. All right, but by definition, serum sodium below 135 is what qualifies as hyponatremia. And this can happen not immediately after physical activity, okay? So if you've got somebody who for one reason or another you checked a sodium and it was a little bit low after the race, you need to educate them about the possibility that this is something that could get worse in the next 24 hours. And if you have these signs or symptoms, you need to seek further help. Okay, so just know that this is something that can continue to get worse. And we'll talk about why that is up to 24 hours after a event. And then this is, again, typically in those longer events. Severe cases can be fatal. There are associated deaths with this. So we want to be able to know how to treat it and identify it quickly. All right, so incidence for Ironmans is around 23%, give or take, so fairly high. This includes mild and asymptomatics. Okay, so this is studies that where people have had their labs done, no matter whether or not they've had symptoms. And so this is for study purposes. And so most of the people are going to fall into a mild hyponatremia, which is 130 to 134. Okay, so keep that in mind, is that most cases are going to be mild. If you've dropped from your baseline, so say your baseline is 142 and you drop down 7% from that, it might be only 133, but you may be symptomatic. Okay, so just know that everybody kind of may have their own set point for this too, and you really want to treat the patient, not the number, right? Know the number, treat the number, but also kind of take a look at the patient. Rates vary all over the board, but you're going to see them longer in those like ultra trail, ultra marathon, 100-miler stuff. A lot of the treatment algorithms from this come from wilderness medicine, because those same kind of groups are oftentimes what are treating those out of the way, not near any tertiary care center situation. And so they're knowing how to field treat. So a lot of the wilderness medicine goes into this. Noakes is a name that's very famous with regards to hyponatremia, has done a lot of the publications on this, and has looked at, of all finishers in endurance athletes, how many have hyponatremia. About 7%, with 1% being a little more on the moderate to severe side. 13% actually are hypernatremics, a little bit dehydrated there. And includes asymptomatic. So that was, again, all comers, all finishers, testing blood sodiums after you come past the finish line. If you have a high temperature, say you're doing a half Ironman in July, potentially higher rates of exercise-associated hyponatremia. This was first described in 1981 for various reasons that sort of are still unclear to me. Prior to this, athletes were advised not to drink during exercise at all. And so what happens? Well, hypernatremia, severe dehydration, several deaths. And then after that, you need to drink as much as possible. So it sort of pendulum swung completely in the other direction. And then beginning in 81, we started to see cases of exercise-associated hyponatremia because of those recommendations that people should drink as much fluid as possible with exercise. It is really a total body water problem that causes a dilution of sodium. So this is not a sodium loss, this is a water gain. Okay, this can occur from excessive water consumption during the race. The problem is that you have too low of a drop in your sodium, you're going to get cerebral edema, and then potentially that is fatal as well. So this is drinking too much hypotonic fluids in excess of what you're able to get rid of. However, think about your kidneys. Your kidneys are amazing filters, right? So in a healthy kidney, which hopefully is the majority of people who are running races, their kidneys can get rid of up to potentially 1 liter an hour of free fluid, right? Sweating, it's hot out, you can lose up to 500 mLs, another ½ liter of fluid. So you could potentially get rid of 1.5 liters of fluid every hour. So you should be able to consume that much, right? No, exactly. So that there's a mismatch here. And the reason for that is vasopressin. So antidiuretic hormone. AVP is sometimes what publications will call it. So there is too much of this floating around in the system. This gets secreted into the body, preventing you from losing too much water, which is going to dilute the sodium out. So that's really the ultimate issue. It is released from the posterior pituitary. Under normal physiologic conditions, it is released in response to hypertonicity, so with dehydration, acts on the kidneys to have them resorb free water, and you're just going to pee less. Okay, so if you have elevated ADH levels, you're not going to be urinating. You're going to be holding on to that fluid, and your urine's going to be more concentrated. Okay. In one study, they looked at 22 collapsed runners, 43% had detectable ADH despite being hypoosmolar. So despite their sodium levels being low, they still had detectable antidiuretic hormone. And then in people who are ultramarathon runners, and again, this is in all finishers asymptomatic, they looked and found that their sodium levels were normal, but they were still releasing antidiuretic hormone. Okay, so this is something that is released in response to exercise. Okay. When you have ADH in the system, you can really concentrate the urine pretty highly, okay? Compared to if you don't have ADH, you can put out pretty dilute urine that is close to water almost. Why this happens, again, it's not entirely clear in the literature. Intense exercise, is this a response to the stress of running a race? Is this in response to nausea, vomiting, low blood sugar, low blood pressure? It's not entirely clear, but it's probably most likely multifactorial. So remember, this is not a losing too much sodium. Although if you are losing sodium, if you're a really salty sweater, that can make it worse. Okay, so you guys have probably seen people who they work up a sweat and they get this nice white line on their clothes. So there are salty sweaters that can make it worse. Gatorade does not fix this. Gatorade does not prevent it, okay? The concentration of sodium and potassium in Gatorade is 23 milliequivalents per liter. Normal plasma is 145 milliequivalents per liter. So Gatorade doesn't do diddly for this, okay? Despite what the Gatorade Sports Science Institute probably wants to tell you. And there's no good data that consuming salt by itself will prevent it. And possibly it's going to stimulate the pituitary to release more antidiuretic hormone. So being careful about like salt tablets and that sort of thing. And in those who had low sodium and compared to normal sodium, looking at what they consumed during the race, there wasn't a big change. And so it's not like not eating enough salt causes it. And again, there are people who will have certain electrolytes during races. Calcium is something that some people like to take in to try to kind of reduce acidity in their muscles. Again, kind of a little wobbly there on the hard science behind it, but that potentially is associated with higher rates of hyponatremia. There was one study that looked at that with ultra marathon or ultra trail runners. So very low or very high BMI can certainly do this. Female sex, if they're exercising for longer periods of time, so over 4 hours, those who are slow runners, less race experience can lead to this. Excessive drinking behavior is probably the biggest thing. So preventing your body from having excess water in it will be the most helpful thing to decrease this risk. And we'll talk about prevention and how, if you're a race planner, how you can kind of think about that. again, higher availability of drinking fluids, seeing somebody running with a Camel pack on, you have to think about this. Medications that they're taking, SSRIs can also lead to this, as can NSAIDs. They can potentiate the release of ADH. And then anything that affects the kidney's ability to get rid of water, which not only includes the NSAIDs, but also a lot of medications out there. Many psychiatric medications can do this too. And extreme hot or extreme cold conditions can lead to this. So you want to think about this also in the first week of football camp, as well as during these longer races. If you have somebody who's gained weight during the race, then you have to think about this as well. We'll talk about race weights in just a second. But if you happen to know whether or not they've gained weight, if they have gained 2 kilograms or more, you have to be quite concerned about this. How do they look? This can look like a lot of other stuff that walks into the medical tent, right? So everything that we've kind of talked about up till now, they can feel a little bit nauseated. They can just feel kind of crummy. They may feel bloated or complain of feeling bloated, or they may even look a little bit on the puffy side to you. Again, if you happen to have race weights, not all races do this. Race weights are fraught with potential problems. And so we can talk about that too. They may complain of feeling dizzy and lightheaded, and they might feel a little bit cramped. Like literally everything that we've talked about thus far can look the same. So you want to get a history. Did they drink during the race? How much? Did they stop at every? Did they bring their own fluid? Have they peed during the race? How many times? How much volume? So getting a sense of how much they've taken in and how much they've put out, if you can. Okay. The more lower your sodium is, the more serious signs and symptoms are, and the more you have to act quickly. They may have, again, some confusion, disorientation, agitation. Again, going along with what Rob was talking about, the more mentally not with it they are, the more worried you have to be, okay? And you also have to think, is this something that could be exertional heat stroke? Is this something that could be hyponatremia? Like there are other things on the list that you need to kind of rule out. And so getting those vital signs and getting that ISTAT in that confused person is a good idea. They may be vomiting in those more severe cases. Phantom running is associated with this as well. And so laying them down and seeing their legs like continue to run the race is associated with exercise-associated hyponatremia, which is kind of interesting. It's sort of a unique phenomenon. Seizures, if they're having seizures, then you have to worry that they're already developing cerebral edema. If they have a decorticate posture, again, this is badness you don't want in your medical tent. You have hopefully transported them before this. If they're experiencing respiratory distress, so not only your brain, but also your lungs can experience the edema that can occur with low sodium levels. So you have to think about pulmonary edema, coma, death from brainstem herniation. And then if they've died, probably too late at that point. But if you've got anyone who's kind of altering or seems to be circling the toilet a little bit with what they're doing in terms of their presentation, you want to be checking. Also remember that you can also have associated acute kidney injury with this too. Okay, so a lot of people who have more severe cases with this are going to end up with an acute kidney injury, and ISTAT does not measure creatinine or BUN. So that is something, again, if you're looking for that, they need to be probably in the hospital. So there have been, again, deaths related to this. So if you happen to be able to do a spot urine sodium, we will not be able to, but we do have an ISTAT machine. And so being able to do a serum sodium and seeing if it's 135 or below, you want to, again, treat the symptoms, not the number. Being just aware of this is really kind of the number one, knowing that this is an issue because it's different than treating exercise-associated collapse, right? So screening someone who you're suspicious of this, and the biggest way to treat this is just fluid restricting them. If they look puffy, if you happen to know that they've gained a little weight, just kind of keep them around, fluid restrict them until they pee. Once they pee, their antidiuretic hormone is going down, okay? And they'll be safe to hopefully leave at that point. You can give them a little bit of food. You can give them some salty pretzels. This is where we talked about that really concentrated bouillon. So 3 to 4 cubes of bouillon in water. It's maybe something we should think about. I didn't even ask if we have bouillon, but maybe we should ask about that. So getting them a little bit of salt to help potentially decrease that antidiuretic hormone in fluid. If they've got anything that like their brain is not functioning, thinking about a hypertonic bolus, which we'll talk about, it's 3% saline. So again, a lot of people have mild symptoms. Oftentimes it's found and it's just like, oh, it's a little bit low. You can give them some of that really salty fluid. Don't let them drink just water. Don't let them drink Gatorade. Gatorade has electrolytes, but it is not anywhere close to the concentration that you need. And then talk to them about, if suddenly you've peed and you're feeling a lot better and you want to go home, that's fine. But if suddenly you're feeling a lot worse, you start vomiting again, you start getting confused, you want to make sure that somebody is with them, they're not going home by themselves, that they're able to seek immediate medical attention. Because as we talked about, you have that 24 hours where this can be an issue afterwards. IV normal saline is going to make it worse. So they should not be getting IV normal saline. All right. So if you have somebody who is more severely ill with this, you want to first make sure that you have IV access, or Jim can do your IO needle for you. And again, no isotonic or hypotonic fluids, getting them oxygen. So the treatment for this is 3% normal saline. So it's hypertonic saline burns going in. Okay. If they're confused, they probably don't care that much. Okay. And getting them 100 cc's over 10 minutes, or just getting them like pushing it in to get it in them quickly, and then rechecking. Okay. This is more for field, so less in the med tent where we're close to a bunch of medical facilities. If you're ever off in the field, if you're treating one of these ultra trail races where people do weird stuff off in the woods and they have all these weird personal protocols that they use, and you're really worried about this, if you needed to push 100 cc's of normal saline, it's probably going to be okay in terms of risk of doing that, compared to the risk of letting them be hyponatremic, even if you're not 100% sure. Okay. And keep in mind, each 100 ml that you push is going to increase the serum sodium by 2 to 5 millimoles per liter. And then once you're doing that, you're getting them ready for transfer. They need inpatient care. They need other labs looked at. They need to be monitored and stabilized in the hospital. So again, inpatient medicine the training that you guys have had talks about, chronic long-term hyponatremia, you don't want to correct it too quickly. This is not that. You're not going to worry about central pontine demyelination in this situation. This is acute. Okay. So you don't need to have that sort of slow going up as you think about with chronic hyponatremia. Okay. This is a fast thing that you want to fix. You can give it quickly. Guidelines differ. Some say 10 minutes, some say give it as a bolus, and you can repeat it. Okay. So if your sodium is 125 and then you get it up to 128 and they're still acting confused, you give them another bolus. Okay. And then getting them ready to transport. There was a publication that was a case series that talked about 7 patients, 6 were treated with hypertonic saline and survived. The 7th had no hypertonic saline and died. So, and this is again out in the field somewhere. We're very lucky where we are in Augusta, where we have a big tertiary care center nearby, but knowing those numbers is really important. So again, just sort of thinking about how symptomatic are they? Are they asymptomatic and for whatever reason you got a sodium, which hopefully that's not the case because we only have 25 cartridges at our Ironman. So please don't unless you really need to. Fluid restricting them, closely watch them. They pee, that antidiuretic hormone is going down. If they're getting worse, then getting some hypertonic saline into them if we can, and getting them to the emergency room. There is something called hypovolemic hyponatremia. It's a subtype of exercise-associated hyponatremia. Important to know about. You can see it more in hot, humid Ironman competitions. This is where you'll see dehydration, hyponatremia in football players as well. So this is people who have been sweating more vigorously, more sustained period of time. and less ability to eat sufficiently to combat the losses of electrolytes that you see. And again, if this occurs, we treat the sodium before we treat the dehydration. So getting their sodium levels back up and then treating their dehydration. The biggest thing is really preventing overconsumption of fluids. And so there are several different guidelines out there. The one that I think is the most simple and makes the most sense is a drink according to thirst. Okay. 400 to 800 mLs per hour. For 800 mLs per hour when you're exercising still feels like a heck of a lot to me. But drink according to thirst. Drink if you're really thirsty. Okay. And you don't want to gain weight. The aim is to lose weight a little bit. Okay. So 0 to 3% of body weight loss, not gain. And then, education, making sure that people know that drinking excess water isn't going to necessarily prevent problems. Understanding that sports drinks are going to prevent it. And then spacing of water stations. There's different guidelines for this. Ironman recommends at every 5 kms for their running component and every 20 kilometers for their cycling component, having an aid station. Marathons, the guidelines are every 2 miles, and then on ultra marathons every 6 miles, or some of those ultra marathons, like you have to take care of yourself, like bring your own water. Crazy people. The consensus guidelines of drinking to thirst are still what is recommended, and that's the British Journal of Sports Medicine. Sodium intake guidelines for this vary. ACSM does recommend that you intake some sodium per liter of water. Possibly for those not drinking beyond sweat losses, this could potentially help prevent EAH. But if you can outdrink your sodium intake. So if you're still drinking 1,000 mLs of water, you can still become hyponatremic despite eating salt. So being able to spot check a serum sodium is important. Potentially having hypertonic saline on hand and get IV access quickly. Limiting your fluid availability on course, educating the public as they're participating to drink to thirst, have a high suspicion in those who are taking other medications such as SSRIs. Just a word on pre-race weights, the issues with them. So number one, you have a scale in the field that is weighing hundreds to thousands of people. It is not going to stay perfectly calibrated. And so the error that you can get on these scales is something that you have to take into effect. You may not have a perfectly level surface if you're in a medical tent. That is going to affect your scale depending on the scale. And you want to make sure that if you have multiple scales, that they are weighed on the same scale that they came in on. Okay. So this is something that some people do and use, but it is not available everywhere, and it is also fraught. So just to be aware of that. All right, so hyponatremia, you're going to have usually normal rectal temperature sodium, that's going to be off. Blood pressure is typically going to be normal. You may look puffy or have some body weight gain. And usually within an hour of keeping them away from fluids and just having them sort of sit and maybe take some bouillon, they're going to feel a lot better. They're going to look damp. They're going to look more moist versus dehydration. They're going to look dry. They're going to look like they have low fluids. They may be hypotensive. They may be orthostatic. And their temps may be normal. They may be a little high. They may be a little low. But remember, there are signs and symptoms that can be present in both: headache, nausea, vomiting, lightheaded, faint, weak, fatigue, muscle cramps, all the stuff that walks into the med tent. So just be aware. Again, this is from Wilderness Medicine, which I think is nice because it also includes heat stroke on this as well as dehydration in addition to exercise-associated hyponatremia. So we've gone through a lot of this pretty extensively. So I'll let you guys peruse it at your leisure. And that's it. So just remember, this is due to overhydration and ADH secretion. Can be non-specific. You've got to have an index of suspicion for it. You want to make sure your athletes are aware to drink to thirst, and then individualized rehydration protocols. Some people just know what they can take in and what they can't. If they're symptomatic, especially if they have mental status changes, you want to make sure you get them to the care that you need. And that is it. That's LAVA. So, all right. Stop share.